Hey y'all, and welcome back to the latest episode of Code Brew. My name is Joe King, and I'm here with my co-host, Lukewarm.
Hey everybody.
Yeah, and we're back. It's episode 8. And I'm
Insanity.
I think I'm most excited about this episode. I mean, I was really excited about episode 1, but I have to say, this is my one. Like I'm like, you were really excited about sepsis. I'm really excited about this one. So this is the final episode in our rapid response series. So that was episodes 5, 6, and 7, and now we're on 8. So the last few topics, the first one in the series was just rapid response basics about patient deterioration and stuff. Then we talked about sepsis and hypovolemia. Last week we talked about strokes and things that mimic strokes. And now here we are. We're talking about Code Blues, highly requested episode. We've had multiple people talk about it, and I'm excited.
Well, the only person that's excited for Code Brew, I guess, students are excited.
Yeah, students are excited. I mean, I do think people get excited about the experience, or they get really scared. You know, I think for me, it feels like a time where, like, I feel like my skills, I don't know, I feel like I'm firing on all cylinders, you know?
Literally have the capacity to save someone's life.
Yes. No, okay, so here's my thing about a code situation or any emergency. I always feel like this. So in these situations that are super chaotic and high stress, I feel like my brain suddenly becomes clear. Like, what is this? Is this ADHD? I don't know.
I pay attention better when I have a lot going on.
Yes, same. Like I know exactly what's going on.
I've met the level of stimulation that I need to function appropriately.
Yeah, it's like the outside world is giving me enough stimulation to match like my brain chaos or something.
Which is why at this very second I'm doing my homework and also the schedule.
And I'm
no, I'm kidding. I'm not.
And I'm balancing a plate on my head, and I'm spinning a basketball in this hand.
No, the only thing that she's doing,
chewing gum, but you can't hear it.
The only thing she is doing is giving me this look that says talking to the microphone.
Yes, always talking to the microphone. Y'all know.
It's a constant stare, and it makes me uncomfortable.
Oh my gosh, it's a death stare. Yeah.
Well,
yeah.
maybe you'll get to shine.
Yeah.
Give me that death stare. Maybe you'll get to shine.
Maybe this will be my time to shine. No, I do enjoy talking about Code Blues. I feel like there's such an opportunity for learning. I feel like there's something that, you know, everybody gets a little intimidated by for good reason, okay? Because someone's life is in the balance. And I want to be able to bring some calm to that chaos. So I'm definitely looking forward to diving in deeper with you today. But as always, first, the disclaimer. The views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or any personal or professional affiliates. This podcast is for educational and entertainment purposes only and should not be considered medical advice. Okay, so what's a Code Blue? So Code Blue is the term that we use in the hospital, right? Basically it's a button on the wall, right, in most hospital rooms, and it's simply saying, hey, I've got a patient who is in cardiac or respiratory arrest, okay? Typically, I think cardiac and respiratory arrest sometimes are used interchangeably. They're really not the same thing, but we're going to respond to these things in the same way. So they kind of fall under the same umbrella for this purpose. So in most facilities, there is a blue button on the wall for you to push if there's a code blue, if your patient is in cardiac arrest.
Oh my gosh, is it really blue? I've never noticed that.
Oh my God, are you colorblind? Yes, it's blue. You work in a hospital. Y'all have no idea what I deal with on a day-to-day.
The color.
It's blue. It's appropriately colored. Color association. So, you know, if you work in a hospital, you know what it means whenever they say code blue, such and such hospital, 3 East, 4 West, 7 Towers, whatever.
Those floors.
I haven't either. But so it just means like, hey, the whole emergency response team for the hospital is headed to that location, right? So triggers for a code blue, your patient is unresponsive, they don't have a pulse, or they are not breathing, right?
Patient doesn't have a pulse. What do I do?
What do you do? So many things, and we're going to go over that. We're going to talk about the different roles during a code. We're going to talk about what is important, what your first things are. But, I kind of thought about how I wanted this to go. And the first thing I want to talk about is the different people you're going to see in a room. Who's going to arrive?
What about before those people get there?
Right.
That takes time. It's not magic. So what do I immediately do? My patient doesn't have a pulse.
What do? You hit that blue button on the wall, or you initiate the code blue for your facility, and that should be...
They were DNR. Is my patient a DNR? That's always good.
That's a wrench.
Is my patient DNR?
Luke loves to stump me. No, he
not a stump.
No, he likes he likes to throw some unpredictable stuff at me.
So they are a full code.
Okay.
I am going to
start
chest compression.
Yes.
And say,
call the code.
You'll probably have an NCLEX question that says, which one do you do first? And I'm doing them both at the same time.
Yeah.
It's call a code and chest compression.
Right.
It's happening.
But for the purpose of NCLEX, what is the right answer for that?
High quality chest compression.
No, actually I think it is. Like if you're by yourself, it is high quality chest compressions, and then you activate the emergency response system, I think. After one round.
You do them both
at the same time. If you could literally multiply yourself.
So low.
Yes, we're not
ever.
Yeah. And that's why we make it easy. That's why I talk about the blue button, because it's so easy to just hit it and get to work.
With my third hand.
Or your ear, or your left toe.
So high quality chest compressions, we're doing it.
The next person arrives to the room, and what do?
Hopefully they bring the code card.
Yes, please bring the code card with the defibrillator, my favorite tool, the defibrillator. Don't be afraid of the defibrillator. If we walk away with anything
and then
from this,
don't have the defibrillator, and maybe the code team is starting to walk down the hallway. Let's put the defibrillator on.
Yeah, put the pads on.
Make sure that backboard's underneath them.
Definitely.
And then be prepared to answer a bunch of questions.
Yes.
Responding team.
For sure. Yeah.
All right. Let's set everybody up for success. So now I think we can talk about the role.
Okay.
I feel like it would be appropriately to talk about.
That's true. So you're right.
To see it as a responder. And what I want to. When I was a new grad, that floor nurse, really scared. I was scared of a code.
A lot of people are, and that's why we're doing it.
And, I wasn't one that was going to, jump up and do chest compressions. I'm like, I'm going to avoid. I mean, if a patient needs it, I'm going to do it. But I wasn't, looking for I wasn't looking for the excitement.
The corner.
I was like, my patients are going to get every single thing that I can possibly give them. I'm looking in, and early intervention will say.
Yeah.
I don't know.
I mean, this is what we're trying to avoid,
but
right?
You can't always avoid it.
No, you can't.
So, what I needed to know then was my responsibility was start chest compressions, activate the code team, code response, code blue, whatever it's.
Right.
Get the backboard under the patient, get the defibrillator on the patient.
Yes.
And
turn it on.
Yes. Okay. And then the code teams arrive and they love it because this person has
done everything you were supposed to do.
Success.
Yes.
And now you just need to be present to provide information.
Once all those things are complete and the code team has arrived and you've been relieved of chest compressions or whatever your role is, then you as the primary nurse, just be ready to answer questions because we got a bunch of them.
Be logged on that computer, have tabs pulled up.
Yeah.
Contact information.
Yeah, if you have your cheat sheet, we love that. Whatever you need. I mean, if you have the computer, we love that. Family contact information, all that stuff. But yeah, no, we have a lot of questions. So, okay. So role delineation.
I feel better.
Do you feel better?
All right, roles are you.
Oh, okay. Okay.
You love roles.
I'm excited about this. So I love ACLS protocol, and all of this stuff is coming from your ACLS. So I just want you to understand what each person is doing, what you can expect from that person. So anyway, so first of all, the first role we need to look at is a team leader. And this is someone who is directing the code and is ensuring that the team is cohesive, that we're doing all the things in the right order. And I mean, it's typically going to be a physician or a mid-level or advanced practice provider like a APRN or a PA, or it might be your rapid response nurse. It can be anyone certified in ACLS. So, if you depending on what your hospital has set up, it may possibly be a rapid response nurse. So, but those people are also nurses are qualified if they've had ACLS. So, we typically would want them to have critical care experience, though. I mean, that's kind of a caveat to that. You can have your ACLS certification, but if you're in hospital, you do want someone who has done it before, right? If you're in a team leader role, you need to have a little bit of experience. So the team leaders are going to be giving you feedback. They're going to be maybe the one asking the most questions, like, what is this patient here for? What was happening immediately prior to the start of the code? Who knows what they're going to ask based on what we're seeing. If we found vomit, do you know what they were eating, when it happened, how long has it been there? If there's bleeding, we may ask lab values. There's no telling, but they're probably going to be
They were probably going to ask all of that.
Yeah, I mean, we're going to ask a ton of questions.
The family.
Yes.
And then we're going to assign roles.
Yes, we will. And team leaders usually assign roles. Sometimes I will say if you have a team, I mean, if you're at like a high level hospital where you have a lot of sick patients, sometimes your team is so well versed and so practiced that they kind of naturally flow into different roles. And so you don't realize that there's role delineation and assignment of roles because you assign yourself based off of, well, this role hasn't been filled yet. So you may see that happen. And that's also normal. You may not be told, hey, you do this. Hey, you do this. But
a clear assignment of roles is very, very, very important.
Yes.
So stepping up and saying, I've got chest compressions.
Yes.
And having that closed loop or that commitment.
You can identify yourself as...
is important.
Yes, for sure.
I don't want to be like, well, Megan's always got meds and she's sitting over there standing by the meds, so she's probably got it.
Right. No, identification is important.
It's time to give epi.
Oh, yeah.
Yeah. And Megan's looking at her watch or something. And,
yeah.
So, clear delineation of roles.
Right. For sure. Yes. The roles need to be, definitely identified. But yeah, you're right. Definitely, Luke. So as far as the team leader goes, like I said, feedback is going to be one of their key components. They're going to be giving clear, direct communication. And we're going to touch on the communication piece a little while later in the podcast. But, that's
because that should really be two-way.
Yeah, it definitely is. We're going to talk about closed loop. We're going to talk about direct, and all those things. But right now on the roles, just know that your team leader is going to be the primary person giving that feedback. So the next one is the compressor. And this person's job is...
Poor RT.
It's very simplified, right? As far as the role is clear. Do your high quality chest compressions. You're going to switch out every 2 minutes. And honestly, most people, I'm not saying all people, because we do have some Hulk people that come in here and they do chest compression for forever. But most people can do, 1-2 minute round of CPR and they really need a break because it is hard work.
I'm pretty impressed. So that's I'm excited to hear about what role you like versus what role I like, and then what role I'm ultimately we can talk about that after all.
Yeah.
But I literally just wrote this down because I was like, there's a specific role I like.
Yeah. Right.
Never get it.
No. Yeah. Right. I mean, somebody's always doing what I like to do too. Here's the thing about the compressor, right? Anyone that has BLS can be the compressor. So this sometimes, I really like seeing my ancillary staff, like my PCAs or techs. I mean, as long as we make sure we know ahead of time that, everybody who works in X role has BLS. And most people who come to work at the hospital in clinical care have BLS. I mean, that's kind of
anyone that's patient facing.
Yes.
Is required to have BLS.
Yes. But also something I love to do, and I'm sure Luke would have hated this as a student, but I love to get my nursing students in. I'm going to be looking around the room. I would like for all nursing students to have done chest compressions on a real human before they graduate from nursing school, because I feel like it needs to get out of the way. you know?
Yeah, I do think that it's really important. That is something that they are very excited about. So just always making sure that the discussion that you have with them about it is in post-conference.
Oh, yeah.
I just, the students are so excited. I did actual chest compressions today. And what does that sound like to, another
It could be,
that's visiting a patient, or if they're walking in the hallways. That's a slippery slope.
It can be, for sure.
So, while you did it, we're only going to talk about it in post-conference.
Oh, yeah.
Post-off area, because being excited about someone passing, or whatever,
that
would not be well received. We all need experience with it.
Absolutely. And I think the other piece is, like, it can be also, like, a very emotional experience for students the first time. I mean, depending on the students, everybody's different.
And the outcome.
Right. And definitely depends on the outcome. But yeah, no, I think it's something like you can almost get like a mental block about it. Like you can become like so nervous about it that you kind of always step back instead of step up. And so that's why I like to kind of nominate students if they're willing. We don't force anybody, of course. But yeah, high quality CPR. So you're going to be getting coached, like you're doing a great job. You're not going deep enough. You're not going fast enough. You're going too fast. So, I mean, you may be getting feedback while you're doing this. But yeah, I mean, this is a great role for anyone who's in direct patient care because they have their BLS certification that they can help out with.
You guys, just so you know, I'm trying to open the lifesaver.
I'm going to kill it for eating candy on the podcast.
I'm trying to be really quiet.
I'm going to kill him.
She's for sure going to take me out. It's so scary sitting across from her when you're just hungry. I haven't eaten today. It's 8:30 p.m.
Okay, so the next role is the airway person. And this is where, you're gonna have your RT. You're also probably gonna have a provider. You have your RT that's over the bag valve mask, providing ventilation, ensuring patency, and then you're also gonna have a provider who's at some point during the code going to establish, going to get your airway, do your intubation. And so it can be, you're always going to have an RT involved, probably. You're almost always going to have a provider involved. An early start of those ventilations, the assisted ventilations with a BVM is going to be important. Please don't forget to attach the bag the BVM to the oxygen, turn it all the way up to 100%. And, I feel like these are simple things, but I mean, they can fall through the cracks, right? So in an excitable state, we do want to make sure that it is hooked up to oxygen. Okay. So that's the airway manager. You're securing the airway, taking the airway, making sure that it's patent, and then providing those assisted ventilations. So next is the recorder. I feel like the recorder is probably the most critical role. I mean, I don't know. It's not my favorite role.
I always get, I'm just going to say it. I always get recorder. Like,
right.
If I am a role, like not house manager, whatever.
Right.
If I'm an active role in the code, I always get recorder.
You want
I want to be meds.
I
don't want to be a recorder.
I like meds. I like being on a defibrillator. Yeah, so I get it. So the recorder, I feel like, needs to be a very experienced person. It is a critical role. The recorder essentially keeps the whole team organized, ensures that the documentation is accurate, keeps the team leader aware of time-sensitive tasks, namely your pulse checks and your epi, time for another epi, time for a pulse check. I mean, these are things that you're going to hear.
Amnio, bicarb, all
right,
of that
repetitively. Yes, they're going to be documenting that thing. Every time we shock a patient, they're writing it down. I mean, honestly, they're recording every moment of the code and also keeping us on task. So, yeah, it needs to be someone who really understands what that entails, right? I mean, the documentation of a code is time-consuming. It takes attention to detail. So, yeah, I mean, this needs to be somebody precision and has good situational awareness. So, also, I have to say, technology can really be helpful. Apps, they have several apps out now that help simplify your documentation and kind of keep you in order while you're doing this. I mean, obviously, you can't try to download those mid-code, right? They would be something you'd want to have downloaded on your phone prior to, or on an iPad or what have you. But yeah, I mean, there's some good ones. I think Code Recorder Pro is one of the ones that we use a lot, but it can help with your documentation. It has like some really quick timers. They have some prompts for medications, for rhythm checks, compressions. It really helps with documentation. So if if you're going to be doing this a lot, that would be really helpful for you. So IV and IO access. So I feel like this is kind of a dual role together with the person doing the defibrillator, right? So once IV access or IO access is established, then this person kind of can transition to being the one monitoring the defibrillator, looking at your rhythm, and also like charging, shocking, and that kind of things. Couple of things like IV access and defibrillator, they're both very important roles. So you want to get your first shock in. If you have a shockable rhythm, which we're going to go over soon, but if you have a shockable rhythm, you're going to try to get that in as quickly as possible, right? I mean, that improves your outcomes. So if your patient does not already have IV access, we're probably not going to take the time to try to establish it. And that could be a central line. I mean, that would be awesome. A peripheral IV or whatever. Those things are all great. If they don't have that, we're going to go for the IO. You can, proximal tibia and the humeral head are the two main sites. So humeral head, I know a lot of times is considered the best site for your code meds because it's quicker. I will say proximal tibia is a lot easier to find your landmarks, but either way, IO access and getting that done. Most places, the ability to place an IO does require a documented competency.
I mean, it's a drill.
It is a drill. You probably want to practice it on something besides a human before you do it the first time on a human.
Yeah, they had us like drill into something like PVC pipes. So
yeah.
See, like, like you're drilling and it's like very hard, and then all of a sudden it's like,
yeah,
it just like goes in.
Yeah. I mean, it's real. If you've never done it before, it can be a little, I mean, I've seen people get a little queasy, and it's understandable. But yeah, I mean, it's quick. It gets your meds delivered, and it's very exciting to have this kind of technology available to our patients, right? I'm definitely a fan. We use it a lot if we have to here, and having it as a backup, if your patients, if we suddenly lose IV access, or something like that, I mean, having that as a backup is really important. So at the same token, we want to talk about your defibrillator, right? So the person who's responsible for the defibrillator is going to be, when you do your pulse check, I mean, obviously, we want the patient to be on the defibrillator, right? Put the pads on the patient, turn the thing on. Please don't be scared of the defibrillator. It's a tool. And I mean, it essentially is like responsible for saving patient lives, right? So, I mean, don't be afraid of it, right? Turn it on. It's not going to shock somebody just willy-nilly. I mean, there's several steps you have to do. Don't be afraid of it, right?
Technically be afraid of
shocking someone
or yourself. So be afraid of it. Be afraid of it in that capacity.
Have
so don't touch the patient when they say all clear. Hold on to a
clear means clear.
And make sure you're saying all clear when you push buttons. So that kind of...
And that's one of the primary responsibilities of your defibrillator nurse is making sure that everybody is clear before you push that button, right? So yeah, I mean, this is a very important role. We want that person to be able to identify the rhythms, because whenever you do a pulse check, we want them to shout out like, oh, they're in PEA. Oh, they're in VTAC. Oh, they're in, torsades, what have you. I mean, this person needs to be able to look at it and see, in conjunction with your team leader, because a lot of times they're going to be two roles. Yeah. So next, your medication manager. Okay. So this is our favorite. Me and Luke both, we like being a medication nurse. So you're always going to have a nurse that's giving the medicine, right? So you're going to be, and it's just a nurse that's doing it. I mean, you might be responsible for drawing up your meds, and administering your meds. I mean, it depends on how many people, it depends on the roles that, the different types of disciplines that respond. But you're always going to have a nurse pushing the meds, right? And you're going to be giving that clear, hey, epi's in, 1 milligrams epi's in.
what does that whole conversation look like? So team leader recorded.
Right.
Team leader's going, hey, we can give 1 milligram of epi.
The recorder's going to be like, hey, it's time for another epi. Okay, 1 milligram of epi. And then you're going to repeat back your vendor. Confirmed, 1 milligram of epi. And then they're going to administer the medication, flush it, and they're going to say, 1 milligram of epi is in. So that your recorder
Epi heard.
Yes. This is basically how
that's like those communications that we could use like just throughout the entire healthcare system.
Oh yeah, for sure.
Like I'll be at facilities or places or just hear, like just a call light go off. The unit clerk answers that, and it's just like 1110 needs to go to the restroom. Like they just shout it out. But like there's no, like it's not closed loop. Like they're just assuming since 5 people are there that
somebody's gonna take care of it. Yeah.
This is like a good example of, hey Robert, 1110 just called out to go to the restroom. Hey Beth, I heard you. I'll take 1110 to the restroom. So that accountability, that acceptance of the task,
yes.
The accountability.
Yes.
So just,
and that's
general moral.
But
this is a skill that we should all work to enhance.
It is in healthcare.
In every aspect of our life, but also healthcare.
Yeah. But in a code situation, it is a way for us to control the chaos. I mean, you have multiple people doing a task at one time, the same goal in mind, but it's going to seem very chaotic for someone who is on the outside, especially, or inexperienced. And I think it's important that we talk about that closed loop communication, because it's going to be very direct. It's going to be very loud. And we're going to talk about that a little bit further, but just remember, like, these things they're direct, they're clear, they're concise for a reason.
Great. So let's be direct, clear, and concise. So our roles are, we've got a team leader.
Right.
We've got a recorder.
Yes.
Probably multiple compressors.
Yeah.
We're trading out because it's tiresome.
We've got somebody on airway.
We've got someone on airway, someone on meds.
Yes. We've got somebody on the defibrillator who is also going to be focused on getting your access.
Fingers crossed we have access. But
yes.
We have this IO gun.
We have a backup plan.
Weird. Is it technically called a gun? I've always called it an IO gun.
I think it's called a drill. I think it's called an IO drill. Yeah. And what does IO stand for? Intraosseous. Intraosseous?
It stands for IO.
Yeah. It just stands for IO. No.
Bone.
The bone.
It stands for in the bone.
Yeah.
Okay.
So
we've got all those, and then, so we have our bedside nurse here that's providing us this information, and hopefully the computer's open.
But hold on, because I have to do my shameless plug for my pharmacy friends, who sometimes in some places respond to help with meds, and I get so spoiled.
Well, I just kind of thought they always did.
Because you work here. Yeah, okay, so I love pharmacists, okay? And we have some great ones that I get to work with. Actually, I've had great pharmacists all along my career who've spoiled me, so that's why I feel this way. But having a pharmacist in a code to do your medication, like prep and like talk about compatibility and dosing and like what we should be using for this or that. Oh my gosh, like it is so awesome. Like this is like a time where your pharmacist really shines, I feel like. So
yeah, it is like, unless you're doing like interdisciplinary rounding, like in the ICUs, like you don't really have much interaction with.
Right.
So
like
it's mother all day long and ask them questions about meds. Like I'm like, oh hey, like tell me about this device, and they're like running away because doing it for 3 hours again.
Yeah.
But yeah, you're right.
No, I mean, I hope my pharmacy friends hear this and like puff out their chest and like walk a little taller. I mean, I'll knock you down later, but no, I mean they do a great job. So yeah.
And then like there's like another like runner.
Yeah.
I mean,
It is
let's
important.
throw a runner in there. Because,
Yeah.
like, somebody get a Doppler.
Right.
Get a stool.
Chin.
Just be
Yeah.
prepared.
No, yeah.
Throw in another regulator, suction, stool, Doppler. So the nurses on the floor of the unit, this is a code outside of the ICU, that don't really know what to do. Like, that's a great.
It is.
They know where things are on that unit. They want to.
Yes.
They're saying that they don't know what to do. And I don't know where the stool is on that unit. I sure want whoever needs that stool to do chest compressions. I sure want them to have it.
I definitely don't know like the code to the supply room because I can't remember any of them. So yeah, no, this is a great role for your floor staff. I mean, it might be a PCA, it might be somebody who wants to help but doesn't have a clear role. I mean, I guess this is an important time to also talk about like crowd control. If you don't have a role, you haven't been assigned a role, and you find yourself being just a spectator, please don't be a spectator, right? Like, if you're not the primary nurse and you don't really have a role and you realize that you're just standing there watching instead of actually doing anything, please, like, go check on the patients.
Check on
the rest of the units.
That nurse.
Like, answer the call lights. Yeah. I mean, like, and also just don't be a spectator, okay? Like, this is something major. Like, you might have family there. And maybe your role can be like, let me talk to the family. Let me love on the family or something, whatever it needs to be. Give them, some care.
Get them a
glass of water. Yeah,
that's where to be.
Yeah, those are important things too. So, but yeah, don't be a spectator, right? So, okay. So some key concepts that improve outcomes during a code. First of all, we've touched on it already. Chest compressions, the sooner the better. I mean, it's critical. I mean, it is like the single thing that absolutely improves survival rates. The quicker you establish quality chest compressions, the better, the higher the chance of a positive outcome, right? Early use of the defibrillator, getting them on those pads, identifying the rhythm, and shocking if it's warranted, right? If you have a shockable rhythm, if they're in VFib or pulseless VTAC, those are the main two that we're going to shock, right? And if rhythm is not shockable, we don't shock them, okay? We don't just shock people for good measure. I need to reiterate that. But yeah, I mean, now if you're in a place, like say you work in a place that has like an AED instead of a defibrillator. So getting those pads on quickly and turning it on so it starts to analyze, and it's going to tell you what to do. So this is valuable. This is going to improve patient outcomes. So getting your resources and getting them, placed on the patient as they're supposed to. So like the pads that come with the defibrillator, you make sure that you do put them on correctly. There are very big, very clear pictures on the packaging of your pads. Please put them in the right place. They don't work the right way if they're not put in the right place, right? So, and in general, you're going to have one that's just below the right clavicle and the other is on the left chest near the rib cage. Okay, another key point, get those assisted ventilations as soon as possible. It's not going to be acceptable just like put them on O2. Like, don't just put them on a non-rebreather or something like that. Like, you need to be giving them assisted ventilations with a bag valve mask. And then, of course, like as soon as you can get a provider there to take the airway, and intubate is going to be key, especially if you have somebody who's a respiratory arrest. If we can get that intubation done quickly, we can start oxygenating better, and then it improves the chance of a positive outcome. So obviously what we're trying to accomplish with your chest compressions is circulation. And what are we trying to circulate? We're trying to circulate oxygen. Oxygen being the key point there, right? So, and then also like get that access. If your patient doesn't already have IV access, we're not gonna stop anything to attain IV access. Like, we're gonna go ahead, we're gonna drill for the IO. Now, if you're someplace where an IO isn't available, yeah, we gotta get it done. We gotta get the IV access. So if that's your role, getting that IV, please take that seriously, right? All right, so let's look at the algorithm. What do you think? AHA guidelines, ACLS protocol.
Tell me all about it.
I am going to tell you all about it. I mean, can you tell this excites me? I mean, go back to your first thing, your high quality CPR, but what does that look like? Your compressions should be 100 and 120 compressions per minute. For an adult patient, the depth is 2 to 2.5 inches. You do want to allow full recoil of the chest. There's several songs, Stayin' Alive. There's some other ones that have like a good tempo for it. Stayin' Alive is obviously our fallback, right? So
what if I'm doing like chest compressions and they like not at this rate?
Clear feedback that says faster, slower, harder, whatever, okay, deeper. I mean, they're going to say, they're going to give you whatever feedback you need. Don't take it personally. We're trying to save somebody's life. It's going to be direct. It probably is going to be loud, so they're heard over all the other people in the room. And it literally, it has nothing to do with you personally. It's like, this is what I need to maximize the chance of having a good outcome for this patient. Okay. You're going to do a round of CPR for 2 minutes. You're going to do those chest compressions for 2 minutes. We're going to encourage you to make it to the 2-minute mark. If you don't think you're someone who can do chest compressions for 2 minutes, if you have like physical conditions that might hamper you, don't step up to do chest compressions, because we don't want to interrupt compressions any more than we absolutely have to. We don't do it in 2 minutes. Why do we do 2 minutes? Because we're going to do a pulse check every 2 minutes. You're going to hear that recorder say, time for a pulse check. And everybody's going to go, pulse check. And you're going to check for a pulse. Where are you going to check for a pulse? 2 places. Number 1, it's going to be your carotid. Number 2, you're probably going to look at your femoral artery.
Sometimes it's good to have a Doppler.
And it is sometimes good to have a Doppler. I mean, it's a lot easier.
You can just kind of like leave it there.
Yeah.
Chest compressions. Yeah. You don't have to find, because, they always say, like, if you can't, like, I feel, like.
Well, it also is a tool for
you're just going to go.
For giving quality compressions.
Yeah. Because you can hear blood flow.
Yes, because you can hear blood flow. So a Doppler definitely is super helpful, right? So
we've done a rhythm check.
Right. So we do pulse.
Checking for pulse.
We're looking at that defibrillator.
And we see the rhythm.
Right.
I just, as the recorder, what are you going to tell me?
I'm going to tell you, I see VFib.
Okay, as long as you tell me. I just want to make sure I don't have to ask for it.
No, you don't have to ask for it. If you're on the defibrillator, then you need to be looking at that rhythm and say, this is what I see. And if it's a PEA, if it's asystole, if it whatever it is.
PEA, resume compression.
Yeah, PEA, resume compressions, right? Because we're going to get that done as quickly as possible. We want to do it. I believe we want less than 5 seconds, or is it 10 seconds? I think it is 10 seconds, right? As quickly as possible, right? Identify that you don't have a pulse, identify your rhythm, resume compressions. Now, if you have a shockable rhythm, do you resume compressions? The answer is yes.
She pointed to.
Yes, I pointed to him.
But she really wanted to answer it.
I did. I'm always that person. Me, pick me. No, absolutely. You're going to resume compressions. And why are we going to do this? Because we have to charge the defibrillator. We're going to charge it to whatever the team leader has said. The algorithm says we start at 200 joules. We can increase it up to 360 joules. As if you see VFib or if you have pulseless VTAC, right? So you're going to charge the defibrillator. We're going to be giving chest compressions while it is charging. Okay, we don't pause chest compressions until it is ready to shock. The person on the defibrillator is going to say charging, and then they're going to say everybody clear. And it needs to be loud, and they need to check around, do a quick scan and make sure nobody's touching the patient. Everybody should repeat clear, throw their hands up in the air, and we're going to shock that patient. And then we're going to immediately resume compressions.
I like it.
Yeah. Okay. Other things. We have 2 other possible rhythms that we would call our non-shockable rhythms. Okay. Those things are going to be PEA, pulseless electrical activity, and asystole, otherwise known as flatline. Okay. if there's not anything going on, I mean, and you may see like a little bit of artifact, you may see like a little bump or something where like the heart may be trying to do something, but generally, if most of the line is flat, call that asystole, right? I mean, and PEA can look like sinus rhythm. I mean, almost. I mean, generally, it's not that organized, but at the same time, it can be, and you can be like, wow, are you sure I don't have a pulse with that?
Yeah, that is.
But if you don't have a pulse, you don't have a pulse, y'all.
Electrical activity, but without a pulse.
Right.
Pulseless electrical activity.
Yeah, and I mean, it just simply means that the pacemaker of the heart is trying to do its job, but the muscle is not reacting to it, right? So some other things we can do, it's, our meds, right? So for your shockable rhythm and your non-shockable rhythms, we're going to be giving Epi 1 milligram. It typically comes in a stick form that you find in your Code cart. It's like a grayish brown box. It's going to be 1 milligram in every stick. It is to be delivered IV or IO, and we're going to give it usually about every 3 minutes, but the algorithm does say every 3 to 5 minutes, okay? We used to give it every 2 minutes, but we don't anymore. 3 minutes, 3 to 5 minutes. We don't want to give it any more than that, right? Something else we can do for our shockable rhythms, your VFib and your VTAC. We have a couple of options for your antiarrhythmics. One of them is amiodarone. First dose being 300 milligrams, second dose being 150 milligrams. You also have lidocaine. And you don't see lidocaine used as often. Amiodarone's usually our first go-to. Provider-specific or patient-specific, they may have, some of your cardiologists really like lidocaine, so it just kind of depends on who you're dealing with and what your patient is presenting like. So, if the patient does not have a shockable rhythm, like I know it feels like we're not doing everything because we're not shocking them, but you can cause more harm than good by shocking your patient, so we're not going to do that, right? You don't shock asystole no matter what they say on the TV, and you don't shock PEA. But however, you do give the epi still every 3 to 5 minutes, right? So let's talk about H's and T's. Luke, H's and T's.
H's and T's.
H's and T's. H's and T's.
Like reversible causes of cardiac arrest.
Yes, they're reversible causes.
So what do we have? We have low volume, hypovolemia.
Yes, hypovolemia.
I guess I should actually call them.
You should use the H. Yeah.
AT.
Right. So hypovolemia.
Hypovolemia.
Yes.
Low volume.
Right.
Hypoxia.
Yes.
Low oxygen.
Yes.
Hydrogen ion.
Yeah.
So really what that means is acidosis.
Right.
Hyper or hypokalemia. We know that is something that really affects cardiac tissue.
For sure.
Really, really, really sensitive to potassium levels. Hypothermia. So, cold temperature slowing down what it's like.
Yeah, it slows everything down, right? You have somebody who's cold, and it has to be profoundly cold, right? We're not just talking about...
we're decreasing the metabolic rate,
right,
which is going to decrease cardiac function.
Right. And so in the hospital setting, this is typically not a cause of cardiac arrest in hospital. However, right, from an ED standpoint, I have taken part in codes because a patient was hypothermic and hyperthermic, to be honest. But yeah, so a patient who's hypothermic, everything is slowed down. And we do have this saying, we do warm them up before we declare someone deceased. If hypothermia is determined to be the primary cause, we won't declare somebody deceased unless we have physically warmed them up to normal body temperature and we still do not have cardiac activity. So other things, so hypovolemia, what are we going to treat it with?
So we're going to volume. And just think about that. So if we have a decreased preload because we have low volume, we're not going to effectively be able to pump out blood through our body, which means we're not going to have blood delivery to our heart, which could cause an arrest, right?
Right.
Same thing with hypoxia. If we have a good O2 delivery source, our cardiac...
And that's why early
assisted
ventilations are going to be huge.
So then we've got the hydrogen ion, we've got the hyperkalemia.
Hydrogen ion, we're acidotic. What are we going to treat it with? Everybody's favorite, Have we given bicarb?
Everybody is a fan.
Everybody is a fan of bicarb. I feel like everybody likes to talk about bicarb during the code. Low and high potassium. I mean, we don't really give potassium, right? But we can give some other things.
See, so privately, you would give potassium cautiously for hyperkalemia. So, dextrose, insulin, and gluconate.
Yes.
So all of those things to shift potassium into the cell. It's not fixing it, but it's fixing it for the moment. What are we going to do? Whatever it is to actually get that out of them.
Get them stabilized so that they can undergo dialysis and stuff. So let's talk about the T.
Okay, so tension pneumothorax, tamponade, toxins like drugs.
Yes.
And then thrombosis. So, I guess like with tension pneumothorax, so we've got pressure that's pushing up against the heart, and we're going to have, like impaired cardiac output.
Right. There's just not space.
Tamponade, so we've got a sac of fluid basically around the heart, and the heart can't pump.
Also with spaces,
ability to pump out toxins or drugs. This is where opiates, whatever.
I mean, we don't see that a ton, but yeah.
Look for antidotes.
Right.
How can we get these things out of this person's body? What can we do to protect their organs? Thrombosis. So, we have a massive clot that, we throw to our lungs. We throw within our heart that's going to impair O2 delivery through blood flow, which is going to compromise function and our ability to have the heart effectively push out. So
good job.
It's fun and exciting stuff. So always consider those. The goal would be to reverse them and see if that fixes the problem.
I mean, and we frequently have like this ongoing dialogue as a team. I mean, there's really a team approach to code response. Yes, there's identified leaders. We have role delineation, but at the same time, we are all working for the same goal. And you will see us have these dialogues. We're like, what about this?
We've addressed this.
Yeah.
This is what we've done. Is there anything that I'm missing? Is there anything anybody else sees?
Yes.
So that open conversation is definitely a plus, and it doesn't just need to be provider down. This is a team environment.
Yeah, because I mean, these kind of things, they can't follow one person, and one person can't see everything. We really respect different perspectives when we're responding to these emergencies. So, okay, so we have saved our patient. We've gotten ROSC, okay? So what does that look like? Post-arrest care, very vital. It's part of the algorithm, right? I mean, because we're still wanting to focus on increasing the outcomes, increasing the chance of a positive outcome, right? So, I mean, obviously, whatever would it cause the initial arrest, stabilizing, making sure the airway continues to be patent, that we're providing assisted ventilations. If we've gotten ROSC, we may switch them over to a vent. We're going to switch them over to a vent at some point. So let the machine take over for that. Respiratory is great about taking care of that. And so the airway and breathing can be taken care of in that way. And then circulation, are they still hypotensive? Do they need pressors? Those are all part of the algorithm. We can address, we have our Levophed, our vasopressin. We've got multiple tools in the toolkit to help stabilize their circulation. Do they need blood? If that's one of the causes of this, do they need fluid? We've got, different options as far as fluid goes. So these are all things to consider when you're trying to stabilize your patient, because getting ROSC does not always equal stabilization. It means you moved out of the code period, but you're still working towards stabilizing the patient to make sure it doesn't happen again. Okay. And in this time period, we may also be getting that transport to the ICU. I mean, if your patient was coded in the emergency department, or God forbid they coded in a pre-hospital setting and you're doing your stabilization in the ED, and then, also if they're inpatient on the floor, we're going to getting them to the ICU as quickly as possible, where we have all those resources available to keep them stable, right? We do have something in the toolkit called targeted temperature management. Lowering that body temperature on purpose to decrease the basal metabolic rate, decrease the demand on the tissues, to, kind of slow the brain down. We do, heavily sedate these patients. We sometimes paralyze these patients because we want to keep them at a low temperature. And that keeps us from doing things like shivering, which is trying to raise that body temperature. Our body has a natural process to try to keep their temperature stabilized. So the target temperature is somewhere between 32 and 36 degrees Celsius. And typically targeted temperature management is for at least 24 hours. And you are going to keep that patient on sedation. And like I said, your paralytics, I mean, you're definitely going to be going to your providers for those orders, but just expect those things. So, I mean, generally, rule of thumb, I can't think of any situation where it wouldn't warrant this. But if your patient has gone into cardiac arrest and we have coded them, they're going to go to an ICU setting. So, yeah. I mean, so I wanted to talk about maybe some personal stories that I've had. I mean, just a few. I mean, we do have situations, and I do want to address like survival percentages and stuff as well. I mean, it's not like TV, right? I mean, I have had, and I can probably count on one hand how many people, but I have had patients who we have gotten ROSC, which, and I don't think I've actually addressed that. ROSC is return of spontaneous circulation. So that's the acronym that we're using is ROSC. That it means we've gotten them back. They have a pulse established, but these patients are not going to talk to you in most cases when they get back. It's not like TV.
You're about to tell us of the ones that do talk to you.
But yeah, I mean,
Get off of me. What are you doing?
Yeah, I mean, really within like the last year, I did have a lady, she was definitely coding. We worked her for, less than 10 minutes. But I mean, she was, definitely coding. We worked her for less than 10 minutes. We got her back and
she was ready to eat.
No, well, she didn't say that, but she definitely told us to get off of her, and she definitely used some expletives. We were very aware of her wishes to get off of her for sure. Because honestly, it doesn't feel good to be coded. So whenever you wake up, if you do wake up immediately following a cardiac arrest, you're going to be in pain. Typically in your chest. So yeah, I mean, it doesn't happen very often. Like I said, I mean, I've been doing this I've been in healthcare for almost 15 years now. And I have on a couple of occasions, less than definitely,
no,
probably less than.
It's for sure pretty interesting.
It is. Like, I mean,
really, hold on.
It really shocks me. Like,
really didn't have a pulse. They have no blood pressure. Like, why are they like,
yeah.
Can you change the TV?
Yeah, I did have a lady one time, and I was travel nursing at this time. We shocked her, and she got ROSC, and I tell you, she almost ran out of the room. Like she was trying to stand up, and it was shocking. And she actually did this to us twice. Like she was having some really funky rhythms. She would go into VTAC, she would lose a pulse, and we would shock her out of it. And within about 30 seconds, she was trying to get up off the table. And yeah, it doesn't always happen like that. It usually does not. I just want there to be some kind of recognition that this is not like TV, okay? But I mean, you can have some incredible moments when you have a successful Code Blue. So I mean, the possibility is there, but it's not.
It does make it look nice. Like the other day, I was watching something and nasal cannula.
Yeah. And I will say this, like as someone who does this on a regular basis, I feel like family members view it in the same way that it is on TV. Like I feel like we're at a definite disadvantage because, obviously like survival percentages, if you go into cardiac arrest, I mean, in the data, I mean, I can give you the percentage. According to the data from the American Heart Association, survival to discharge from the hospital when you have a cardiac arrest in the hospital is about 20 to 25%. Okay.
So what's your thought on family and room?
I'm
just gonna tell you, I'm a fan.
Yeah, I mean,
if they're distracting and
right.
like running around and interrupting care provision, different scenario.
But as
seeing that everything that is being done,
right.
Like one understanding what full code means.
Yeah,
because I think sometimes although we explain it over and over and over, like this is what's going to happen, I don't think sometimes their ability to process,
right.
Well, last week, Granddaddy was playing baseball and Bell and Hay. So, you can't process stuff
Right.
that quickly.
No,
I get it. So, it's not that I'm saying any.
don't work in healthcare, who are not familiar with healthcare, they don't have a realistic view of it. And they really don't.
Well, TD.
Exactly.
But, to also be able to see, wow, we did everything.
Yes.
Everything.
That can give people closure.
There is a sense of closure to that. Yeah.
So
I think, I feel like in the past, I don't know, it's like when I graduated almost 15 years ago,
right.
I feel like maybe what they were teaching at the time, I don't remember, but wasn't, it was almost like to remove the family.
Right.
I can't think of what the specific scenario was, but I know current practice is actually to try to.
People do have the right to be there.
Keep them in the room so they can see what's going on. They can see what we want everything means.
Yeah.
And also have maybe the comfort of, dad did not want this.
Right.
Or I am making the right decision. No, we can't go through this again.
Yeah. I mean, I think, and the flip side to that is this is a traumatic experience for someone to witness for their family member. So if they're going to be in the room, I do feel like we need to have someone who's designated to be there to give them care. This person is going to stand here. They may have questions. They may not have questions. They may need you, they may, their knees may buckle. Get
them a chair.
Yeah, for sure. I mean, this is a traumatic event, so make sure that you're giving the family some care. It may not be your role, but if it is your role, it is important.
And also the understanding when we're upgrading to the ICU, hey, I'm going to take you to where their new room is.
Yeah.
There's going to be some settling in,
Yeah.
So you need to wait outside in the waiting room, and we'll come get you once.
For sure.
Once we've got them settled in, lined, whatever it is, whatever that care provision looks like at that time.
For sure. So, and we go back to those survival percentages, right? I mean, 20 to 25%, and that's if they're actually physically in the hospital at the time of the arrest, okay? 20 to 25%. I never
knew the percent. I knew like the propensity to code again was always very high.
Right.
Once you hear it once.
Yeah. So, I mean, and I don't even want to get into the out of hospital percentages because they're much lower. And that's unfortunate. So so if you're thinking about,
I keep you around.
Yeah. Right. Mm-hmm.
Don't get tired.
Yeah. But yeah, I mean, 20 to 25%. If you think about it, you're talking about 75 to 80% of your codes are not going to make it out of the hospital. So,
and just think, so regardless of like your heart is stopped, so something is wrong with that. Like we've had, no matter how great our chest compressions are, our ability to create perfusion in your body to provide all of your organs, an optimal environment to thrive, oxygen, ATP production, glucose,
it's not
whatever.
Perfect. It's not the same
It's not going to be a great amount of delivery.
Right.
In the best case scenario, with the highest quality chest compressions that, exist, it's not going to be your map of 65.
No, it's not. And how do we improve those outcomes for our patient? It's those early chest compressions. It's getting the defibrillator on. Limited interruption of your chest compressions and early defibrillation of your shockable rhythms. And then, effective care in the post-ROS phase where, you're doing that TTM, getting them stabilized as quickly as we can, and making sure they have, that we're getting them moved where they have the most resources and whatever those resources are based on those H's and T's that we've identified. So,
in closing.
Yeah. So, I think I want to go over like advice for new nurses and code participants. Like we said, this was like a highly asked about episode. And I think a lot of people identified this as like, hey, I had ACLS. I was a new grad. I thought I was ready, but then when it happened to me, I didn't know what to do. Well, it's one of those things where you're like, oh, I don't know what to do with my hands. Okay. No one expects you to know exactly what to do. That's why you have these teams of people who are experienced. That's why you activate the code system, right? So even if you've taken ACLS, that doesn't make you an expert, right? So lean on your more experienced staff in those situations. But the encouraging thing is we want you to participate. We want you to learn. Stay calm. Focus on the role you're given. You're the primary nurse. Answer those questions to the best of your ability. Yeah, I mean, it's a team approach. So, like, you don't have to shoulder the burden of responsibility. Nobody shoulders the burden of their responsibility. We take it as a team. And we debrief as a team. And yeah, I mean, I think that's one of the reasons I really enjoy responding to Code Blues as much as you can enjoy is because we do work so well as a team.
It is interesting.
It is, yeah.
How well people can
right.
together and naturally assume things.
Right. So, and I did want to touch on the direct communication. We've talked about it. So you're going to get that feedback. Please don't take it personally. I mean, I've had situations where, like,
it's not criticism. If something is telling you
it's feedback.
Faster, deeper, it is what is best for the patient. That's their job to observe and to make sure that the patient is getting what they need.
100%. Like, someone's life is hanging in the balance. I can't be worried about someone else's feelings about it. Right? I mean, we have to give those feedback. Like, and I'm never going to be mad at you. I'm never, and this goes for everybody. Like, we're just being direct. We're not, it's not, there's no emotion involved, right? And it's definitely not personal. But the feedback is essential to make sure that we're maximizing the chances of those positive outcomes. So
it may be something that we could discuss in, like, the debriefing after.
Oh, yeah. 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 And you're gonna get, if things are running the way they should, the way I'm used to running them, you're gonna get positive feedback too. Like, hey, good compressions. Like, I feel like a broken record sometimes. Like, hey, good compressions. Like, but sometimes you need that feedback. Sometimes you're like, hey, you're doing a great job. You're almost there. You got 20 seconds left, and you're like, man, I'm really gassed, but hey, I'm doing a good job, so I'm gonna keep going. The positive feedback is just as important, right?
Shout out to me during the code. Hey, good job recording.
Oh, well,
could you tell me next time? Like,
no, 100%. You're right. It's typically compressions.
Everyone else gets the positive feedback.
Right.
I don't know if the recorder gets the positive feedback.
I think I've ever been like, hey, good job pressing, pushing that plunger in on that epi, or hey, good job with that BVM. Like, I think it's pretty much just compressions that were like, good job, because it's so physically taxing that people were like sweating and like, I mean,
it'll wear you out for.
I mean, I had a situation where, like, my glasses fell off. I was giving compressions one time. I mean, like, and
yeah, I can't believe you haven't shouted out to RT. So pharmacy got it. But no shout out for RT that, like, literally lines up.
Oh my God. I know. You're right. I've neglected it. RT.
Over and over again. The front of the line, that's the chest compression. Back of the line.
I know.
Front of the line, back of the line.
Oh God.
Or a 45 minutes.
Right. Oh God. I'm gonna get hate mail from RT. I love RT. You do an excellent job of making sure that, like, we don't have to think about the airway from a nursing standpoint, because we know RT's got it. They do volunteer to do chest compressions. I love that. They're key members of our team. And honestly, I love RT because they suction people and I don't have to do trach care. So there's my plug for RT. I love you guys.
Do you have to do trach care? I
know we have to do trach.
It's a shared responsibility.
It is a shared responsibility. You're right. But it is definitely one of my least favorite things. Probably a lot of people feel that way. But I appreciate
so easy.
You guys.
It's so easy.
I know. I appreciate you guys for real. RT's amazing. So yeah, debriefs, and we've talked about having debriefs, but I do want to say, like, I feel like debriefs after a Code Blue are essential. I like a formal debrief, especially if, like, the situation is kind of traumatic, but it doesn't always have to be a formal debrief. I mean, I do always like to touch base with a primary nurse after the fact and say, hey, are you good? Do you want to talk about anything? Because I do feel like sometimes that primary nurse carries that weight around with him or her, and I never want that to happen. We cannot prevent these things. Sometimes we can, but a lot of times we can't. I mean, these are human beings, and we can't control everything. But yeah, the other thing about a debrief, some places, some providers, some team members suggest a moment of silence for someone if they do pass. Like, hey, let's take a moment. I think it's a good way for us to, like, acknowledge the life of a human, acknowledge that the life of a human is over. And it lets us maybe move on in a healthy way, I hope. I think as healthcare providers, like, it's very important for us to not lose sight of the fact that these are human beings, right? So that's my 2 cents about it. So our tip for new nurses, right? Stay calm, stay focused on what your role is. Every action, no matter how small, is critical, right? Every role is important. Speak up. If you see something, if you feel something isn't right, your voice matters, and we are saving lives. So just remember, like, these things are important and no thing is too small, right? All right.
You did a really good job.
Well,
Joe, you did a really good job.
I appreciate that.
I took notes.
Did you? I was really excited about this topic for sure. So a few things. Listen, if you have a crazy Code Blue story, or if there's something that you think we should have covered, a tip for someone, something that you've seen that you think works great, I am always up for some feedback. We love for you to interact with us on our social media, on our email. Our email is codebrewpodcast@gmail.com. And yeah, I would love to hear some of your stories, or if there's something we could do better, definitely let me know. I'm always up for some feedback, right? Don't forget our merch store, codebrewpodcast.myshopify.com. See what's on there. It's fun stuff, stylish stuff, because I think it would really excite us to see somebody out wearing their Code Brew merch, or carrying around like a water bottle with Code Brew on it or something. Thank you for tuning in. I hope you've enjoyed the Rapid Response series. Yeah, this is 8 episodes, right? I mean, it's crazy. We've really enjoyed it, and we'll see what happens next. We've got to come up with a new series, and we've got some things to work on. So, as always, stay caffeinated, stay curious, and y'all, we'll see you next time on Code Brew.
Holler.